This is Dr. Howard Strassler. Today's lecture is on caries as an infectious disease. This lecture is made up of 3 individual modules. Module A is on the etiology and caries risk. From the images you see in this title slide, you can see on the left-hand side what appears to be occlusal caries. We need more information to make that diagnosis. As compared to when we look at the radiograph on the right-hand side, we can see the arrows pointing to a definitive caries diagnosis based upon radiographic evidence. For this lecture, the readings come from Operative Dentistry, the Summit Textbook, Chapter 4. When we review the caries process, that we look at caries as being bacterially based. It's formed by through plaque. Plaque is a bacterial biofilm that produces acid as a byproduct of its metabolism, and that acid attacks the enamel and dentin, the mineralized tooth structure. It diffuses into the tooth until finally it reaches a critical mass, and the acid in fact dissolves the hydroxyapatite of the enamel, and it demineralizes the dentin surface. You put all those pieces together and you can make the diagnosis of caries. Caries in fact is a combination of looking at the bacterial plaque, the bacteria itself, the patient's diet, and the implications of diet on feeding the bacterial plaque, how long the plaque is in contact with the teeth, the time necessary, the duration of exposure of the teeth to the bacterial plaque, and then a look at the host resistance, and that refers to the fact that the enamel, the dentin, has different resistances based upon the composition of the hydroxyapatite of the mineral surfaces. We can modify that host resistance through the use of additives to the enamel, to the hydroxyapatite, predominantly the use of fluorides to make the enamel more acid resistant. So let's review the caries process. The 2 most important groups of bacteria are those that produce predominantly lactic acid. We have Streptococcus mutans, mutans streptococci, and we have lactobacilli. And they're slightly different both in microscopic appearance and where we predominantly find those bacteria. When we take a look at the caries etiology, the caries etiology is bacterially mediated. If you take a look at this line drawing, that we're looking at pit and fissure occlusal caries, and that the zone of primary destruction is in this occlusal pit and fissure. It penetrates the enamel, and you have the zone of penetration until it reaches the dentino-enamel junction. The dentino-enamel junction, that you see a lateral spread along the DEJ, creating demineralization and a continuance of this zone of penetration. In front, the leading edge of this zone of penetration, of this zone of destruction, is a zone of sclerosis of the dentin. And in fact, the bacteria, the pulp itself, responds to this leading edge of bacteria and the acids and toxic byproducts that are produced by creating, through the odontoblastic processes, a histologic reaction in the formation of reparative dentin, also known as reactionary dentin. That the pulp, the tooth, is trying to move faster in the formation of reparative reactionary dentin than the caries process itself. When the caries process overwhelms the tooth, the caries can then move into the pulp, and the bacteria will cause a zone of necrosis to the pulp, and the pulp can become non-vital, and you'll see the need for endodontic treatment. And so you see that there's a balance in the caries process. That balance is in fact the balance between caries and health. In fact, there's an equilibrium between the protective factors of saliva, antimicrobials, and fluoride with a caries-free, caries-resistant effective diet as compared to the bad bacteria, the bacteria that are forming the caries process, the mutans, streptococci, and the lactobacillus. That saliva has a protective means, and with the absence of saliva, we're going to see through xerostomia that the teeth will be at risk, the caries process will continue more rapidly. And the saliva not only contributes a washing over the tooth surface to keep the plaque not forming as rapidly and as sticky on the enamel, but also the saliva has protective immunoglobulins that have an impact on the tooth itself. And the saliva contains salivary minerals that also contribute to the remineralization, this balance between demineralization and remineralization. And then we have the patient's dietary habits. What are they eating? How are those dietary habits, the intake of sugar, of acidic foods and beverages, and what impact that has upon this caries balance? So the primary caries is formed by pathogenic bacteria, and the pathogenic bacteria we're referring to is Streptococcus mutans, basically a round form of bacteria. Here we're looking at some histologic slides, some microscopic images of this bacteria. And this is a pathologic bacteria that is responsible for the primary caries process. Lactobacillus acidophilus is and Lactobacillus baricus, that these rods are responsible for the progression of caries. Once the caries process has become entrenched within the tooth structure, the lactobacilli act and colonize the tooth and lead to the continuance of the caries process. And you've had information in your microbiology course that really has explained more about how these bacteria interact with the tooth and how they are responsible for the caries. When we're making decisions for interventions, it's really based upon the risk assessment of the patient of the teeth, that we classify patients as being either high risk, moderate risk, or low risk based upon given risk factors. And you'll learn about these risk factors and how we classify patients based upon the presence or absence of existing restorations, the presence of absence of carious lesions, the presence or absence of defective or successful restorations. And so when we're doing our treatment planning, we're in fact doing different risk assessments. Being operative dentistry, our primary concern is caries risk assessment, the assessment of the hard tissues of the tooth structure and how at risk is this tooth structure to the caries process. We also, as part of our treatment planning, look at our periodontal risk assessment. Is the patient at risk for periodontal disease? And also we're, through our oral cancer exam and going through the patient's medical history to see if the patient's at risk for oral cancer. So we're going to create a management strategy for caries based upon an assessment of the caries risk. Through that assessment, we're going to look at the current and predicted level of caries risk. We're going to use this based upon clinical evidence. Is there significant plaque? And we're not looking at plaque as, is it specifically strep mutans or is it specifically lactobacilli, but is there plaque there? Plaque may be pathogenic or it may be non-pathogenic. When we stain plaque, when we use erythrocin dyes to stain plaque and look at how the plaque sits around the teeth, we're staining not necessarily pathogenic plaque, but we're staining all plaque. We're going to question the patient on the use of fluoride. Are they using fluoride dentifrices? Are they using fluoride mouth rinses? What's their past history of fluoride intake? Did they live in an area where the water was fluoridated? All that's going to come into play. We're going to look at the patient's salivary flow. Is the salivary flow adequate? Is it normal? Is the patient xerostomic? We'll review the patient's medical, dental, dietary, and social history. When we look at medical, we're looking at, are there any drugs the patient's taking that may impact upon salivary flow? Do they have any medical disorders that may have an impact upon salivary flow? An example would be a patient with Sjögren's syndrome, a patient with a past history of salivary gland cancer, a patient with surgical removal of salivary glands, or perhaps radiation or chemotherapy having an impact upon salivary flow. We're going to look at the patient's dietary history. Is there a high sugar diet? How often is the patient taking in sugars? Does the patient have, with this dietary history, what sorts of foods are they taking and beverages? Are they drinking acidic beverages? Are they ingesting acidic food? And their social history. What sort of eating regularity are they having? When are their meals scheduled? Are they eating between meals? All these things are important things, and in your treatment planning course, you'll be going through collecting data to help you in making a decision about patients' caries risk. You're going to look at patients' current caries activity in the lesions you're detecting. You're looking at the location of these lesions. Are these lesions located interproximally? Are they on smooth facial or lingual surfaces? Are they pit and fissure caries? How rapidly is the caries progressing? And we base that upon the patient's recall history. Is the patient being seen on a regular basis, and in their last dental visit they had no caries diagnosed, and now in this next visit we see that we've found 5 new carious lesions. We're going to look at the appearance of the lesions that we see. Are these lesions remineralizing? Are they hard, resistant to the penetration of a explorer? Or do we see soft, sticky areas? Do we see areas of cavitation? Do we see around marginal areas carious lesions forming around existing restorations? These are all going to help us in how we decide on managing the patient's current caries risk. When we look at the patient history, medical history, as I mentioned earlier, that we're going to look at conditions and medications that can affect salivary flow. There are many medications that decrease salivary flow. In fact, patients using tricyclics, patients using medications to control mental illness, many times we'll see decreases in salivary flow. We're looking at conditions. I mentioned Sjögren's syndrome. Patients may have conditions or have been treated where the salivary flow is decreased, and we can assess salivary flow through different types of testing. So that we're looking at a variety of things that may have an impact upon the patient's current condition and caries risk. The patient may have conditions that affect manual dexterity. They may have arthritis. And using the toothbrush and keeping the teeth clean may not be possible. We may decide to make recommendations from a manual toothbrush to the use of a mechanical toothbrush. There may be conditions that affect patients' host response. That can include salivary flow. That can affect the fact that the patient has a compromised immune system. It could be due to chemotherapy. radiation therapy in the treatment of cancer. Or the patient may just have poor immune response that's idiopathic. And most importantly, the one that we can really point to is diet. Looking at the sugars, the refined carbohydrates the patient's ingesting, looking at whether the patient's ingesting acidic foods, beverages, the frequency of ingestion, as it relates to the patient's oral care. We put all of these things together in helping us really come up with a picture of the patient's caries risk. And so when we look at the patient history, we also have to include the patient's dental history. Has there been a past history of high caries experience? We can determine that by the fact that we look in the mouth and we can see existing restorations. We can note this from our radiographic survey and radiographic evidence. We can see whether the patient has existing caries presently, even after having recent dental visits. Does the patient belong to a family where lots of other people in the family have high disease-missing filling teeth? Do patients, that patient's family have also a history of lots of fillings, or perhaps extraction due to toothaches? All of these things should come up when you're giving your history. You also want the patient's dental awareness. How often do they go to the dentist? Do they make regular appointments? When was the last time they were to a dentist before they came to the dental school to see you as a patient? Were the visits on a regular basis, coming back every 6 months or every year? Or did they only come in when they had a dental problem, a broken tooth, a toothache, that brought them in? When you greet the patient, one of the first things you want to talk to the patient about is, do you have any problems? Does the patient have a chief complaint? Do they have symptoms? Those symptoms may be that they have teeth that are broken and it's sharp to their tongue. Or perhaps the teeth hurt when they eat, or their gingiva, their gums are bleeding. Perhaps they have sensitivity to hot and cold foods when they breathe in air. They can't eat ice cream or perhaps drink cold beverages. That all of these things will help form a picture as to some of the expectation. And remember, you're doing some of this before you even look in the patient's mouth. You're just collecting data. Does the patient use a fluoridated toothpaste? We look at fluorides. Have they ever used fluoride mouth rinses? Have they ever had a history of orthodontic treatment, which may contribute to risk? So fluoride exposure, what toothpaste they're using, what rinses they've used in the past, what's their fluoride IQ? Do they understand that fluoride helps prevent tooth decay? You want to talk to the patient about their oral hygiene regimen. How often do they brush their teeth? In fact, when was the last time they changed their brush? You're going to ask them what toothpaste they're using. In fact, as part of your initial assessment, you in fact want to review with them how they clean their teeth. Maybe you can help them do it better. And when you speak to the patient about oral hygiene, as it relates to caries and periodontal disease, you want to tell the patient, if they're brushing their teeth frequently, that it's not as much about brushing as are we brushing adequately? Because they're doing a good job of making the time, perhaps we have to show them some ways of orienting the toothbrush, of using the toothpaste to get it. And then the patient's diet. Certainly a patient who comes in chewing gum, you want to see whether or not they're chewing sugarless gum. Do they suck mints? Are they a smoker? What's their normal breakfast, lunch, and dinner? And a patient with a high caries risk by their clinical assessment, that you may want them to fill out a dietary diary to see what they're taking in and perhaps give them some guidance. what beverages they're ingesting, energy drinks. All of these things can contribute, and it means that you have to do some work as well to understand what are high risk to caries foods, refined carbohydrates, acidic beverages, what puts patients at risk. We're going to look at clinical findings that may indicate an increased risk. The clinical findings would be the amount of plaque on the tooth. We can do testing to determine colony-forming units of Streptococcus mutans, which may give us an indication of teeth that are at risk for caries. Do they have a high proportion of cariogenic bacteria? Is their diet rich in fermentable carbohydrates? Are they eating candies? Are they sucking mints? Are they ingesting on a frequent basis sugared beverages, energy drinks that are sugared? Is their diet, are they drinking a cup of coffee in the morning and they're putting in 2 teaspoons of sugar? All of these contribute. Are they a juice drinker? And the acidity of the juice may have an impact upon dental erosion in caries. Looking at salivary flow, if the patient tells you, my mouth feels dry, I'm drinking water all the time because it's dry, I have a hard time with that. Or you look at the medications. Low salivary flow may lead to low salivary buffering capacity. And saliva buffers the acids on the teeth from the foods and from the bacteria that create the need for restorative dentistry. Look at the numbers of restorations. The larger the restoration, the more there are margins. Margins that in the future may become defective, may have gaps, may be niduses for the bacteria to sit, areas where plaque can be retained and lead to additional caries. When you do your clinical assessment, you're going to look for early signs of caries. Do you see white spot lesions? Do you see demineralization? Do you see demineralization, remineralization? Does the patient have existing orthodontic brackets or bands on the teeth? You're going to look at newly erupted teeth, mostly first and second molars, because newly erupted teeth, the pits and fissures on the occlusal, should be sealed within 6 months of eruption. And that may be difficult to do because of the soft tissue that sits on that occlusal surface as it's erupting, and placing sealants may be difficult due to isolation. Patients with recession and exposed root surfaces, that these are areas that may be at risk. And we may need to come up with prescriptions for fluorides if we see softening of those root surfaces. Teeth that are crowded, rotated, as I said, the existing of orthodontic appliances, patients who wear partial dentures that don't take them out, all can contribute to plaque retention and increased caries risk. We're going to look at natural retentive sites on the teeth, the presence of deep pits and fissures on the teeth. We're going to look at other natural retentive sites, which may be the presence of defective restorations that are retaining plaque, and plaque can sit and not be easily removed. We're going to look at retentive sites due to past dental treatment. Perhaps the patient has an under-contoured restoration or an over-contoured restoration. Perhaps there's a defective proximal contact where food is being impacted and retained that's contributing to plaque retention. And the more the numbers of restorations, the more there are margins, the more the teeth are at risk for future caries. Keep in mind that if a patient has an existing restoration, that meant that there must have been plaque retention, that these were areas and sites of initial carious lesions. Now the placement of restorations doesn't mean we've cured the disease, but rather those areas at risk, if they haven't been addressed through oral hygiene, through fluoride mouth rinses, fluoride toothpastes, are going to get recurrent decay. So all of these things come into play when we think in terms of increased risk. So how do we define caries risk? Well, we can define high caries risk as 2 or more lesions, carious lesions, in the last 3 years. Only 2 is sufficient to say there's caries risk. A high disease-missing filled surfaces of the teeth, A large number of exposed root surfaces can contribute to a high caries risk. Poor oral hygiene contributes to high caries risk, as do irregular dental visits, not coming in on a routine basis and only seeking perhaps care for emergencies. If we do an assessment of the patient's microbiologic presence of Streptococcus mutans, we can look if they're elevated, the numbers of colony-forming units are high, the patient will be at risk. Dietary risk factors, as we mentioned earlier, a high diet in refined carbohydrates, a lot of acidic foods, and one thing we didn't talk about is patients who have gastroesophageal reflux disease, where the acids aren't coming from outside, but rather are coming from the GI tract, and the hydrochloric acid is acting to dissolve the teeth and putting the teeth at greater caries risk and at risk to dental erosion. Inadequate salivary flows and inadequate fluoride exposure. Is the patient using a fluoride-containing toothpaste? And I remember on one occasion a patient didn't want to have anything other than a natural toothpaste. And not all natural toothpastes have fluoride. Some of them do, and probably the most popular being Tom's of Maine, that you have to specify and look to see if fluoride, at least therapeutic levels of fluoride, are present. All of these come into play. Patients with a moderate caries risk will exhibit one caries lesion in the past 3 years. You may still see exposed root surfaces that put it at risk, and the patient has fair oral hygiene. We can help them be better at removing the plaque from the teeth and lowering their risk. Irregular dental visits, not coming in on a regular basis for recall, seeking only emergency care, and that radiographically and clinically you're seeing new incipient primary carious lesions. Patients who have orthodontic or prosthetic treatment are also at risk because there are more marginal areas, more plaque retentive areas that are present, and that would describe the patient as being at moderate caries risk. A patient with low caries risk are patients who have had no caries diagnosed in the last 3 years. All the restored surfaces are clinically acceptable. The patient has good oral hygiene and can demonstrate good oral hygiene. You can see that they remove plaque adequately. A low diet of sugar and refined carbohydrates, and they seek regular dental care. They come in every 6 months, once a year, routine dental radiographs for diagnosis. They don't come in because of emergencies. They come in to make sure they stay healthy. And Ogden Nash once said, a famous Baltimorean, that we go to the dentist so we can avoid going to the dentist. And regular dental visits assure that our dental needs will be less than if we seek irregular care. So patients with low caries risk are going to get their routine cleanings and routine exams and typically won't need any treatment. Now, we talk about caries as an infectious disease. When a patient has carious lesions, when a patient has periodontal disease, we should be telling the patient that they have an oral infection. It isn't just another cavity, it's an infection. In fact, that infection can spread through the tooth until it finally impacts and affects the pulp, giving you a pulpitis, an irreversible pulpitis, and then a necrotic pulp leading to the need for root canal therapy. If you want to see patients become fearful, tell them they need root canal treatment. They need a root canal, and patients only hear bad stories about them. You never hear about good used car salesmen, good insurance salesmen. You only hear the worst. Well, when you have the need for endodontic therapy, you only think of the worst. When we look at caries as an infectious disease, we really want to look at a specific plaque hypothesis. Only a limited number of organisms in plaque cause caries, Streptococcus mutans, lactobacilli. And in fact, the patient who has a great deal of plaque being retained on the teeth may not have any caries or periodontal disease if the plaque isn't pathogenic. So we're looking at those bacterial species that are pathogenic. In fact, our treatment is aimed to target those bacterial species that cause caries. Now, we can't brush our teeth to just remove the strep mutans and the lactobacilli. We're actually going to be looking at that we're removing all plaque because we can't discern the difference. When we stain plaque to show the patient how much is on the teeth and we score, do a plaque score, we're staining all plaque. We're not staining just pathogenic plaque. As I mentioned earlier, the two primary groups of organisms involved in the caries process are mutans streptococci for caries initiation on the enamel and root surfaces. And then once the caries has gotten within the tooth and we have the zone of destruction, we now see lactobacilli within the tooth. So we look at caries as an infectious disease. When we treat this infectious disease, our aim is to remove all the sites for bacterial colonization. And then we specifically target cariogenic organisms. How do we do that? Well, as part of our treatment in urgent care, we're going to restore all frank areas of cavitation. We're going to restore all areas where there are defective restorations that are areas where plaque is being retained. We're going to demonstrate to the patient how to keep the plaque from the teeth, giving them instruction and giving them fluorides and telling them what toothpaste to use. And for patients with a very high caries risk, we may actually use antimicrobials. In the short term, we may have patients rinse for a week with chlorhexidine rinses to beat back the bacteria. And so we're doing this as a treatment for an infection. The same way if you were running a fever and they found that you had strep throat, you'd be put on antibiotics. Well, antibiotics are too much of a shotgun for plaque and for caries. And so we're treating caries more in a localized area. We're going to gather all our diagnostic information. When we gather that diagnostic information through our having the patient fill out a medical history, through our questioning the patient about their past dental history, their current dental conditions, their frequency of visits, how they keep their teeth clean, and we do our clinical exam, both radiographically and clinically, looking at the hard tissues and the presence of existing restorations, defective restorations, and teeth. That will make some decisions. That will identify caries risk as being low risk, moderate risk, or high risk. We'll look at the current use of fluoride-containing dental products. We may do salivary testing, and the salivary testing will be looking at the bacteria that are present and the salivary flow that the patient has. We'll look to see the buffering capacity of the saliva. The recommendations that we'll make for prevention and treatment after assessment will be made based upon what we're seeing.